Okay. So after the excitement of transvenous AVM embolization, I'm going to talk about the intrasaccular flow modification and long-term results with multiple angiographies. Placing an intraneurysmal device inside the aneurysm sac at the level of neck, disrupting the intraneurysmal flow, create aneurysm thrombosis and flow remodeling. We are talking a lot of flow remodeling. And this is immediately after the placement. Good contrast stagnation. If you wait on the table and the patient was not on the is not on the and on anti-aggregation, you may see even immediate occlusion as well. But this is 6 months control on this patient. Usually, however, it takes a very short time to have a occlusion. Web device really brought simplicity to our practice in selected cases. For example, in this particular patient, placing a web device inside the aneurysm is good enough. Otherwise, you need to reconstruct the bifurcation, putting maybe 2 stents. But this was a over the 70-year of age ruptured patient. Can you imagine how you can coil this aneurysm with this large neck? But with the web device, it is very straightforward, and this is the end of the treatment. Very fast solution because the patient is not on anti-aggregation since he is a ruptured patient. Very easy. Let's say not easy, but you know, it makes more straightforward. Compared with other more complex solutions for such bifurcation aneurysms, web device brought an indispensable simplicity and practicality to endovascular treatment. It could be used as a sole treatment, and sometimes we can combine with other techniques. Here are the some examples that we used web device for treatment. So you can think about how cumbersome the treatment can be in some of them at least. So they are not very easy cases. And the operators show interest in the system that the engineers improved the material in the last years, and at the moment there is device compatible with 17 microcatheter as well for 3 to 7 millimeter size. So it is the same size, same profile microcatheter with what we use for coiling. So it is getting better and better. This was a ruptured case too. And at the ICA terminus, you may have worried about protruding coils into the parent artery, but web device, very good contrast stagnation. This is for our curiosity, basically 24-hour MRA and 6-month, 1-year control, very stable result. Another one, ugly looking nipple, ruptured one, and web device placed. And this is 2 weeks after this patient had multiple aneurysms. So we took the patient after the acute period to treat the other aneurysms. So we were able to see how it looked like in 2 weeks' time. This was the case that was treated during WLNC live course in Shanghai, a wide neck aneurysm. So we may have needed two stents to reconstruct the bifurcation, but with web device, it is straightforward. And the 1 year control showing very stable result. This one I treated during the WLNC 2017 in LA. That one device, the contrast stagnated in the nipple. This is post-operative. These are post-operative. And then 1 month MR angiography. And these are the 6-month control, complete occlusion. Proximal support is very important. You should have a good support. So usually we prefer 5 French Navian for proximal support. For this ACOM aneurysm wide neck, no need to worry about preventing the vessels. One device. The most difficult part, or the part that takes most of the time, is the sizing of the device, because it is the secret of it. It is its success or you getting into trouble. So you have to take your time to do the sizing. It is the most important part. 6-month control on the same patient. Another example. 1 year control and 2 years MR angiography. Basilar tip with long-term follow-up, 3 years follow-up. Another one, not all aneurysms are like boxes, so this is a little bit more irregular, but still, if you select good sizing, it's a good treatment. This is 6 months, and this is 2 years. Now comes the question, or comes the discussion. Is it important, this recess? Because up to this point, I showed you the ideal results, not majority are ideal. So is this a good result, or do we need to follow up it? That's why another good example, actually, this time, another ACOM, very nice result. 2 years control, very stable. The stability of the aneurysm occlusion, especially the remnants, are controversial regarding this technique, actually. Because in many of the aneurysms, you may have such a enlarged neck in the control, either in the first control or in the second control. So what are we going to do with those? Are they important? Do we need to retreat them? So that's why in Turkey we planned together 100 aneurysms to obtain at least 2 consecutive angiographies, so that we can see the fate of this remnants, because it is not always that ideal result. Actually, and in that series, mortality is one patient only, and the total ischemic rate is 5%, which is acceptable. And for example, what are we going to call this? You remember the flow diverter case that I showed, MCA? It's kind of similar, or it looks like that one, but this time it is intrasaccular flow modifier, web device. So we use the same, actually, classification for our follow-up. To see, and this is for the intrasaccular one, an example at 3 months. We call this remnant, which is class 2 occlusion, but if it stayed same for a year or at least 6 months apart, then we call it remodeling. And in that group of patients, multi-center, complete aneurysm occlusion, which means only class 1, there is where there is no remodeling or neck remnant, whatever, it is only 28%. So don't get the impression, because I showed you good examples at the beginning, that it is a 90% result. It was in the first follow-up only 28%. In 70 or more than 72% of the aneurysms, there was some kind of remnant in the first follow-up. However, in the consecutive follow-ups, only 10 out of 92, which is around 11%, it stayed stable. So 89% of the aneurysms remain stable either with class 1 or class 5 occlusion, which means you don't need to do anything else for these patients. For example, we don't call this complete occlusion, but class 5 occlusion. But see, 1 month MR angiography, there is some remnant. And at 6 months, you realize that it is the continuation of the superior trunk. This is 1-year control, and this is 2-year control. It is the continuation of the vessel. So it is stable remodeling of the bifurcation, which means there is no need for retreatment. It's a stable occlusion. It is not so-called complete occlusion, maybe, but it is a good occlusion, stable occlusion. What about this though? It's more controversial. So at 3 months, it is remnant, class 2 occlusion. 9 months, it is stable. 20 months, it is still stable. So do we need to retreat that one? We think that because it is stable, we are not retreating this one at the moment. But if it gets bigger, then we may think about retreating it. So at the moment, it is stable. And also the intrasaccular modifiers work somehow like extrasaccular or luminal flow modifiers, the flow diverters. If you take the origin of a branch, if there is good anti-aggregation and no thrombus formation during the treatment, then in the follow-up, according to the flow demand, the fate of the branch is determined. In this scenario, the aneurysm is occluded. The inferior trunk where the VEP device took or compromised, it got smaller. So it is class 1B occlusion, complete occlusion, but the branch is smaller. Or in this one, the superior trunk origin is taken by the VEP device. However, there is flow through it. These are 6 months, and it is 2 years control, the stable appearance, still antegrade flow through that because there is flow demand. So it is very important keeping the effective anti-aggregation in those patients as well. However, as I said before, sizing is very important. If you undersize, this is the case that was treated by one of our fellows in elsewhere, and then he referred the patient to us, VEP device. However, while he was releasing it, it moved, so he pulled back and placed it again. If you can move the device during your placement easily, it means you undersizing. And this is what happened in that patient. And after the release, it rotated. So it is normal that it came back with aneurysm remnant. It is aneurysm remnant. This is not the same thing. It's the failure of the treatment. So we ended up treating this with Y stenting plus coiling. There are many good, there are some good clinical practice studies, and the results, combined results, 2% morbidity, no mortality in in those, and occlusion results is around 80% adequate occlusion. And in the meta-analysis, this time I hope I'm not miswording anything, treatment mortality is 1%, morbidity is 4% in that meta-analysis. No difference in ruptured versus unruptured, and the adequate occlusion rate is 85%. Adequate occlusion is complete occlusion only in 40%, around 40%. So it is not like black and white. As soon as it is stable and stays the same, it is good enough. And there is VEPIT study. The case collection has already been completed. Many centers, we are among them. There are other people here among the participators. And we don't have the efficiency evaluation yet, but the morbidity, mortality, very good numbers, less than 1% morbidity, and no mortality in that group, and it's gonna come. The good thing about the devices, you can combine with other things. It does not hinder using other devices. In this particular patient where we placed the VEP device, we thought that there is encroachment on the bifurcation vessel, and it is the left side. So we decided to put a stent so that we will secure this vessel. And at the beginning, it may have been very difficult to catheterize this branch. However, by using the VEP device as the support, it was so straightforward. So we put a regular stent. It was Aquino at that time. And this was the 6-month control, stable results. So it doesn't prevent other devices being used. And especially in the ruptured patients, it may save the situation so that you can do the treatment or complete the treatment after the acute phase. I'm going to show lastly 2 examples. This patient presented with bleeding, and the blood is mostly around this aneurysm, which is not surprising. We first wanted to treat this one, and it was a very wide neck, and the A2 is coming off from the sac. So we decided to put a VEP device and then put additional coils so that VEP device will work as a barrier for our coiling. And then we also treated the other aneurysm. However, we didn't try to catheterize this branch in that setting, in that session, because we worried about moving the materials inside the aneurysm, because we needed to get into the aneurysm to catheterize the A2. And after the acute phase, 6 weeks after, we went to the distal aneurysm, put another VEP into that one, and then put a solitaire at the neck of this one so that we can change the flow and have more support. And this is the 6-month control on that patient. Occluded. This is stable occlusion. So it saved the life of the patient, actually. And this was more terrible. This patient presented with big hemorrhage, and the aneurysm is really ugly. So we decided to put a web device so that there will be no worry about coil protrusion, to save the acute period. Well, it would not save, but at least decrease the risk of the acute period without giving any anti-aggregation or anything. 6 weeks later, there is the remnant, also the baby aneurysms at the neck. So, and also another aneurysm at the bifurcation below. So what we did was we catheterized flow diverter so that it would take the neck of this aneurysm, the index aneurysm, as well as the one proximal. And 6 months later, there is remodeling here, and also the large aneurysm is gone with the bifurcation remodeled. So it definitely brought a new tool to our hands for some difficult cases. It provides solution. However, we need to follow up the remnants, if there is any, if they are going to be stable or not. In our 100 patient group where we have follow-up over 90%, we have 11% of how to say regrowth, I would call, and we retreated half of them. The other half, we're going to decide what we are going to do, but they were not stable. So thank you for your attention. And again, please come to Kobe.